This is not a promotional marketing video. This video is intended for patients about to be admitted for surgery for serious gynecological conditions at Royal Surrey County Hospital. Your surgery may vary slightly and, if so, this will be outlined to you by the team when you are seen a few days prior to your surgery. At this appointment, your consent for surgery will be obtained and any of your wishes will be noted.
Hello, I'm Anil Taylor. I'm a consultant gynecologist and a cancer specialist with over 30 years of experience in the field. My expertise is in the surgical treatment of all gynecological cancers, including all ovarian cancers. In this video, I would like to explain what is involved in surgery for a suspicious ovarian cyst. Ovarian cysts are usually diagnosed on scans, but these scans cannot tell us for definite whether they are cancerous or not. They can be about 85 to 90% accurate, and the only thing that can tell us with 100% accuracy whether the cyst is cancerous or not is through pathological examination. However, to achieve this, we have to first remove the cyst and give it to the pathologist to look at it under the microscope. That means you have to have surgery to remove the cyst first. When we're dealing with cysts which have been highlighted as suspicious, we are usually reluctant to biopsy them because that could puncture the cyst and spread any cancer if it is cancerous. Sometimes for small suspicious cysts, we may consider removing them via keyhole surgery, but even this has to be done with caution because we do not want to spill any contents inside your abdomen. Therefore, most usually, surgery for suspicious ovarian cysts involves making a cut. Often that is a midline cut from the belly button down. We tend not to make bikini line incisions for cysts because if the cyst is cancerous, then we will not be able to assess areas in the upper abdomen to check whether the cancer has spread or not. We do this in the same operation as I will explain in a few minutes. Preparing for surgery for a suspicious cyst can be a big moment. And I want to make sure you feel as informed and as prepared as possible for your upcoming surgery. In this video, I will walk you through the key aspects of the operation, what we aim to achieve, and the potential risks you should be aware of. The main aims of the surgery are to achieve two things. Firstly, we want to make a quick diagnosis as to whether it is cancerous or not. And secondly, if it is cancerous, then to take biopsies from all the other organs that ovarian cancer can spread to, so that we can determine how far the cancer has spread. This will then give us information about the stage of cancer and what further treatment you will require, such as chemotherapy. Therefore, let us talk about how the operation will unfold on the day. After you've been put to sleep, we will make the cut on your abdomen and quickly get to the cyst. As long as it is not stuck to adjacent tissues, we will be able to remove the whole ovary with the suspicious cyst in about 10 to 15 minutes. We will send this cyst to the pathologist immediately so that they can start processing it. This is called frozen section analysis. The pathologist is able to get a result back to us in theatres within 30 to 60 minutes whilst you're still asleep. During that time, if you are postmenopausal and no longer need your womb or the other ovary, we will carry on and do a hysterectomy, which usually only takes another 30 minutes. After the pathologist has had a look, they will call us in theatres. If the pathologist tells us that it is cancerous, then we will need to take biopsies of other organs. Amongst these will be the need to remove the omentum, which is a fatty apron inside your abdomen where ovarian cancer often spreads to. This fatty apron does not have a vital function and you can live perfectly adequately without it. The The other place where ovarian cancer can spread to are the pelvic and para-aortic lymph glands. You have many lymph glands all over your body, and they are involved in your immune system. We have to remove some of these lymph glands to check whether the cancer has spread to them. Removing these few lymph glands will not affect your immune system in any noticeable way. In addition to the lymph glands and the omentum, we may also decide to remove your appendix, as some ovarian cysts or cancers are caused by problems in the appendix. Once again, removing your appendix will not affect you in any noticeable way. So, we have discussed what will happen if the pathologist tells us that the cyst is cancerous. Now, let us look at the other end of the spectrum. If the pathologist tells us that the cyst is benign or non-cancerous. In that case, we will not need to remove the omentum or the lymph glands or the appendix. We can then stop the operation and close your abdomen. However, sometimes we may choose to take a small biopsy from the omentum just in case. This is because the frozen section analysis is about 85 to 90% accurate. The final diagnosis will only be available after the full analysis of all the specimens, and this result may take 2 to 3 weeks. Very occasionally, the pathologist may find an area that may have been overlooked during the frozen section analysis, which then turns out to be cancerous on the final diagnosis. When this happens, we are then facing the dilemma of whether to repeat the operation, to go in and remove the omentum and lymph glands a few weeks after the first operation. In order to avoid this, we may sometimes decide to take a small biopsy from the omentum before closing the abdomen. And of course, after doing the hysterectomy, if the pathologist tells us that it is a benign lesion. Now, we have talked about the two extremes of the spectrum, where the pathologist tells us that it is cancerous or tells us that it is benign. There is a third possibility, which is that of a borderline tumor. These cysts are not quite cancerous, but they're not completely innocent either. They are best removed and can rarely spread to the omentum. For that reason, if the pathologist tells us that it is a borderline tumor, then having completed the hysterectomy, we will take out the omentum and perhaps the appendix, but we will not need to remove the lymph glands. So far, we've discussed what happens if you are postmenopausal. What if you are still premenopausal and have functioning ovaries, or your family is not complete? You may still want children in the future. In that case, we will tailor your surgery accordingly. Essentially, after removing the main cyst and having sent it to the lab for frozen section analysis, we have the option of waiting until the result arrives in an hour and then proceed accordingly. If you have completed your family and do not require your womb for future pregnancies, then we may have the option to do the hysterectomy, but not take out the other ovary just yet. This saves time and also ensures that you are under the anesthetic for a shorter duration. If you are premenopausal, taking the other ovary will put you into a sudden menopause. Therefore, if the cyst turns out to be benign, then you have the option of keeping the other ovary. However, if the pathologist tells us that the cyst is cancerous, then that option is not available because the other ovary would need to come out. This is because there could be a small deposit of cancer in the other ovary that is not obvious to us, and only the pathologist will be able to confirm this after looking at it under the microscope. Therefore, having saved the ovary in the first part of the operation, we would take it out before the end of the operation, instead of doing another operation another day. As explained earlier, if it is cancerous, we would then also take out the omentum and lymph glands and appendix. Similarly, if the pathologist tells us that the cyst is borderline, then often it is advisable to remove the other normal ovary unless in exceptional circumstances where the patient is very young and an early menopause is not desirable for other reasons. Now, I know that so far there has been a lot to take in. However, there is another scenario that I have not discussed yet. I have explained that the cyst would be quickly removed and sent away for rapid testing. Occasionally, when we open the abdomen, in addition to the cyst, we also see lumps scattered in the abdomen. These are called peritoneal nodules and may be on the omentum or bowel surfaces or on other organs. When we see this, it means that the cyst is cancerous. Benign cysts do not produce this appearance. Therefore, since we now know that the cyst is cancerous, we will not send the cyst for frozen section analysis and simply proceed to carry out the full hysterectomy and take out the omentum and any suspicious lymph glands if present. We will then also proceed to remove all the scattered lumps and try to clear the abdomen of all visible tumor. This is called cytoreductive or debulking surgery. In some cases, if there is cancer and it is affecting other organs such as the bowel, then we may need to remove part of the bowel or the spleen or any other affected tissues. But these decisions are made during the surgery based on what we find at the time. If you have bowel surgery, then depending on which segment of the bowel has been removed, the rejoin that we make sometimes has to be rested in order to prevent any leakage of bowel contents in your abdomen a few days after the operation. To rest this joint, we sometimes have to make a stoma bag, which in most cases is temporary for a few months, but rarely it can be a permanent bag. However, please note that most patients having bowel surgery don't actually need a bag. Whether you require a bag is a decision we will only be able to make during your surgery. The overall surgery can last 1.5 to 2 hours if the frozen section result is reported as benign, or it could be about 3 to 4 hours if it is cancerous, because we are having to take the other biopsies as mentioned earlier. It's natural to feel nervous, but I want to reassure you that you will be in the hands of an experienced team who will be closely monitoring you throughout. Now, it's also important to talk about the risks. As with any major surgery, there are immediate risks which you should be made aware of. These include bleeding, which might occasionally require a blood transfusion. There is also a risk of infection, such as wound infection, urine infection, or chest infection. We take every precaution to minimize these risks, but they can still occur and can delay your recovery, and sometimes also delay your chemotherapy, which we would be keen to avoid. Another possibility is accidental damage to surrounding organs. This is not very common, but can include injury to the bowel, bladder, ureter, diaphragm, spleen, pancreas, or blood vessels. If this happens, we'll address it immediately during surgery, but once again, it may prolong your recovery. Another serious risk is that of forming blood clots in your legs, which could dislodge and travel to the lungs. This is very serious if it happens, as it can cause sudden death. We will be very keen to prevent this using special stockings and daily blood thinning injections for 4 weeks. You or a relative will be taught how to administer these injections after you go home. However, the best method of preventing blood clots is by becoming mobile at an early stage and getting you out of your bed. We will therefore be very keen to get you up and into a chair on the very next day. We will be encouraging you to take a few steps around your bed and around the ward. This will be uncomfortable initially, but you must give us your full cooperation to achieve this and prevent blood clots. Cancer surgery, pelvic surgery, long surgery are all strong risk factors for developing blood clots. That is why it is so crucial that you help us by becoming mobile quickly. After surgery, you'll spend a few days in the hospital. The first couple of days may be uncomfortable, but our team will manage your pain carefully and support you as you begin to move around and start eating again. You may spend these initial 48 hours in a high dependency area with close nursing observations. We will then get you to the general ward for further recovery and eventually try to get you home by about day 4 or 5. Your subsequent recovery at home will take a few more weeks, but will be with you every step of the way. When you're admitted, and just prior to the operation, you will get a chance to meet the anaesthetist. They will discuss your pain relief options after the surgery. Broadly speaking, there are 2 main options that you should consider. One is an epidural, which stays in for the next 2 to 3 days, providing you with pain relief. The other option is that of having wound catheters placed at the end of surgery whilst you are still asleep. These catheters slowly trickle in a small amount of local anesthetic in the wound and can also give you pain relief for the next 2 to 3 days. Whilst epidurals can give you deeper pain relief, they can also affect your blood pressure and can slow your mobilization and your discharge from the high dependency area. For that reason, I much prefer my patients to have wound catheters rather than epidurals, unless there are other very good reasons for having an epidural, which the anaesthetist will explain. These wound catheters can also provide good pain relief. In the 24 hours prior to your admission or just prior to your operation, you will also be given a strong laxative or enema to clear your bowels. This is in case you require bowel surgery. I know this has been a lot to take in, but please don't hesitate to ask any questions. My goal is to make sure you feel confident and supported as we move forward together. Amongst our team, there are dedicated senior specialist nurses who will introduce themselves to you and will be in constant touch with you immediately following your discharge from hospital. They will help you troubleshoot any problems that you may be encountering after your discharge. If you are having surgery under my care, then you will have an opportunity to meet me in person a few days prior to the operation, and you can ask me any questions that you feel you are still unclear about. At this appointment, you may be asked to sign a consent form, going over all that I have just mentioned in this video. Finally, I would like to assure you again that you will be looked after by a dedicated team of experts who will try and get you back on your road to recovery. Hopefully, your cyst is benign. I shall look forward to meeting you in the near future. Thank you.